Okay. Okay, welcome back, guys. Now in this today's class, let's discuss about the remaining platelet disorders. Already in yesterday's class, we have discussed about the disorders of primary hemostasis as well as the disorders of secondary hemostasis. We have discussed about the disorders. Now in this today's class, let's discuss about the miscellaneous conditions. Also, we'll discuss about the thrombosis and embolism, the important points which are needed for your exams. Okay, I'm going to teach only those points which will be important for your exams. Okay. So the first topic which I want you to know is disseminated intravascular coagulation. Okay, disseminated intravascular coagulation, which is shortly called as DIC, a very important topic. See, in the name itself, it is there. Disseminated means throughout the body. Okay, many multiple places in the body. Intravascular means within the blood vessels there is coagulation happening. So unnecessarily throughout the body there is this clot formation happening. Okay, so this is absolutely pathological condition. So pathological what? Pathological widespread microthrombi throughout the body. Okay, throughout the body, leading to blockage of the blood vessels, leading to the blockage of the blood vessels, that is leading to ischemia. Ischemia means decreased blood flow because of this microthrombi, ischemia and infarction. Okay, so the pathologically in this condition there is activation of clotting cascade. There is pathological activation of the clotting cascade which results in platelet microthrombi throughout the blood vessels, multiple places. So that is leading to decreased blood flow, that is ischemia, leading to infarction of the tissues. Okay. Now, sir, in this condition, what exactly is happening? See, this is called as, this DIC is called as consumptive coagulopathy. Consumptive means consumption, there is some consumption happening. Which consumption, sirs? Unnecessarily the clotting cascade is getting activated, clot formation is getting activated. So it's consumptive coagulopathy. Okay, consumptive coagulopathy. Unnecessarily all the clotting factors are being used up. So what happened to the clotting factors? The clotting factor levels goes down. Clotting factors are decreased. So as the clotting factors are decreased, see, unnecessarily the clots are being formed, guys. Okay, unnecessarily the clots are being formed. Wherever you require the clotting, in that place now clotting is not happening. Okay, unnecessarily if the platelets are getting used up, the clotting factors are being used up. So wherever their need is there, wherever we require the platelets, wherever we require the clotting cascade to happen, there it's not happening. So that will lead to bleeding. So the consumption of these clotting factors is the one which is going to cause bleeding. Okay, bleeding will happen. These patients are going to have bleeding. Now, why, sir? Why this disseminated intravascular coagulation? Why unnecessarily, pathologically the clotting cascade is being activated? If actually there is some higher problem. Okay, there is a primary problem is there. As a result of this primary problem, secondary to this primary problem, this disseminated intravascular coagulation is happening. See, there is primary etiology, primary problem. Or is there is some main etiology is there. This etiology is leading to the secondary disseminated intravascular coagulation. Now, my question is, what is this primary problem? Okay, what's happening in the body that's leading to the DIC? First problem which I want you to know is obstetric related complications. Okay, obstetric complications. So what are these obstetric complications that are causing disseminated intravascular coagulation? See, the obstetric complications, actually there is a list, especially in the exams, they will ask you which of the following obstetric complications can lead to disseminated intravascular coagulation. Let me write one by one. Amniotic fluid embolism. Okay, amniotic fluid embolism. See, there is a complicated delivery, for example, imagine there is a complicated delivery. during this delivery, what is that complication? You see, the amniotic fluid, whatever is there, the amniotic fluid, that amniotic fluid is entering into the mother circulation. Okay, that amniotic fluid which is rich in tissue factor, that amniotic fluid have tissue factor, sir. Okay, in yesterday's class I have discussed tissue factor, that is the clotting factor number 3 activates 7, 7 activates 10. In yesterday's class I have discussed. So the amniotic fluid which is rich in the tissue factor is going to enter into the mother circulation. In the mother circulation, this tissue factor is going to activate the clot formation, is going to stimulate the clotting. So in the mother, because of this amniotic fluid embolism, as the amniotic fluid is entering into the maternal circulation, the mother, clotting is going to form. The widespread coagulation cascade is getting activated. So mother is going to have intravascular thrombi formation. That's the one reason. Second one is abruptio placenta. So what exactly is this abruptio placenta? The abruptio placenta means, the name itself is a placenta which got abruptly separated, premature separation of the placenta. Okay, so the placenta, for example, when it was supposed to be like, the separated during the third stage of labor, right? During the third stage of labor, first baby is delivered, then the placenta is separated. Okay, delivered. What if, for example, a mother is having some trauma, she had some accident, okay, she had a fall, by 32 weeks. 32 weeks, the placenta is little separated. Now what happens? Now there is a damage. Now bleeding will occur. Now what happens is, see, this is a tissue that is getting damaged, placenta. Now the tissue factor, whatever is going to be released, okay, the tissue factor, whatever is released, the tissue factor enters into the maternal circulation and can trigger the coagulation cascade. So abruptio placenta can lead to DIC in the mother. Very important. This is a very, very important thing, abruptio placenta. Okay. Next, amniotic fluid embolism. Next, things like postpartum bleeding. Okay, postpartum hemorrhage. Okay, postpartum means even after the delivery, there is hemorrhage happening. Postpartum hemorrhage, that can also trigger the disseminated intravascular coagulation. Okay, next, preeclampsia. Preeclampsia or eclampsia. Okay, next, septic abortions. Or IUD, intrauterine death or intrauterine infections. See, all these are the conditions. Okay, the main important thing which I want you to know for your exams is this one. Amniotic fluid embolism and abruptio placenta, these two. Okay, see, they are the primary problems which will cause unnecessary activation of the clotting in the mother, leading to disseminated intravascular coagulation. So obstetric complications can lead to DIC. Completed. First one completed. Second, what else, sir? Okay, what else? Second one is sepsis. Okay, there is sepsis in a patient. This is the first problem. Okay, obstetrics complications. Let me put it this way. Second, sepsis. Sepsis means what? Infection in the blood. So sepsis with certain bacteria like E. coli. Okay, E. coli or Neisseria meningitidis. Okay, so Neisseria meningitidis. See, these bacteria, whatever are there in the blood, do you know what they will do? Now, this bacteria, sir, this bacterial endotoxins from the bacteria. Endotoxins. So, these endotoxins, they will activate. Okay, these endotoxins, they will induce the endothelial cells. Okay, they will stimulate the endothelial cells to release tissue factor. Now you know tissue factor is clotting factor number 3, activated clotting factor number 3. 3 is going to activate 7, 7 activates 10, 10 activates 5, 2, 1, you know it. Okay, you know the thing, right? So what I want you to know is, sir, sepsis in septic conditions, the sepsis can cause unnecessarily. Okay, there is no damage to the blood vessel. See, there is no problem with the blood vessel, sir. It's absolutely all right. Pathologically, clots are getting formed within the blood vessel. When? During sepsis or with the obstetric complications. True. Okay, what else is certain types of cancers. If the patient is having adenocarcinomas, adenocarcinoma of stomach or adenocarcinoma of GAT, some like colon. See, these adenocarcinomas, in the name itself, it's there. Adeno means glandular. What they will release? They will produce mucin. Okay, so this mucin, if it enters into the blood, it stimulates the mucin activates the clotting cascade. Okay, mucin activates clotting. Okay, mucin activates the clotting, so unnecessary clotting is going to happen. Next, adenocarcinoma completed. And certain types of cancers, the fourth cancer is acute AML, you know it, right? Acute promyelocytic leukemia, not acute myelogenous leukemia, sorry. Acute promyelocytic leukemia. Okay, acute promyelocytic leukemia, it's a type of blood cancer. Okay, WBC, cancer to the WBC. See, in this condition, the patient is going to have, I hope you have already done this in your oncology. Okay, acute promyelocytic leukemia, which is also called as M3, these cells will have R rods. Okay, so these WBC, inside their primary granules, they have certain vesicles called as primary granules. These primary granules, they contains substances, okay, they contain substances which can actually activate the coagulation. So a simple way, no one will ask you how it's exactly going to activate the clotting. Which of the following conditions are a risk factor for disseminated intravascular coagulation? One, obstetric complications, and you have to know the list. Which obstetric complications? And sepsis, true, adenocarcinomas, acute promyelocytic leukemias, and fifth one, which I want you to know, is rattlesnake bite. Okay, rattlesnake bite. So this rattlesnake bite, when it bites, its venom, whatever enters into your body, okay, the venom, it's going to activate the clotting. A rattlesnake, hemotoxic. Okay, it's a rattlesnake. It's a hemotoxic thing, right? It's a hemotoxic. It's going to release the venom, which is hemotoxic. What exactly it will do is it activates the clotting. So intravascular clots are going to form. So you know it. At the end of the day, the point which I want you to know is that there is some primary problem. That primary problem is the one which is leading to disseminated intravascular coagulation. Okay, if there is intravascular coagulation, what happens? What are the laboratory things that you will see? Lab findings. See, in lab findings, what happened to the platelet count? Okay, what happened to the platelet count? What do you think? Tell me. Sir, I have said you, it's a consumptive coagulopathy. Unnecessarily platelet microthrombi are forming, upon which the clotting factors are getting activated. So it's a consumption, platelet consumption, clotting factor consumption. So the platelet count is going to go down. Okay, unnecessary platelets are being used. As the platelets are going down, so what happened to the bleeding time? Bleeding time also increases. Bleeding time increases. What happened to PT-PTT levels? Sorry, PT-PTT times. The PT time, that's the prothrombin time, and PTT, they are going to be elevated. Why they are elevated, sir? Why? Because consumptive coagulopathy, all the clotting factors are being consumed. So PT time, PTT time, intrinsic factor, intrinsic pathway time, extrinsic pathway time. So this is the intrinsic pathway, this is the extrinsic pathway. Both times are elevated. Okay. Next, what else? So these patients are going to have schistocytes. Schistocytes in the blood. Sir, what are these schistocytes? In yesterday's class also I have explained you. See, there is something called as microangiopathic hemolytic anemia. So there is some problem in the microangios which is leading to hemolytic anemia. Examples are thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, okay, thrombotic thrombocytopenic purpura because of the Adam TS13 deficiency, hemolytic uremic syndrome because of E. coli virotoxin, E. coli O157H7. Yesterday's class I have discussed. See, in this condition also, tell me one thing. Sir, unnecessarily within the blood vessels, look, unnecessarily within the blood vessels, there is formation of platelet microthrombi. See, these thrombi are forming unnecessarily. So when the RBCs, when they are going within the circulation with high velocities, the RBCs are going to stuck to this platelet microthrombi and the RBCs are getting sheared away. They are getting damaged. So leading to hemolysis. So the damaged RBCs, okay, RBC was supposed to be like this. Now the RBCs is going to look like this. Okay, the damaged RBCs. So they are going to look like a helmet. Okay, they are going to look like a helmet. So These RBCs are called as the cystocytes. Cystocytes are helmet cells. So such cystocytes are seen. Yes. So can I say something like this? Disseminated intravascular coagulation (DAC) can lead to MAHA. True, it's true. Disseminated intravascular coagulation, yes, it's a cause of MAHA. MAHA means microangiopathic hemolytic anemia. Yes, there is some problem within the blood vessels. Microangios means unnecessarily these clots are being formed. So that is leading to hemolytic anemia. True, cystocytes will be seen. Apart from that, what else, sir? So these patients are going to have elevated levels of super high levels of D dimers. Okay, super high levels of D dimers. Now you will get a question, sir, what exactly are these D dimers? The D dimers are nothing but fibrin degradation products. Fibrin degradation products. Now you will get it out. Sir, what are these fibrin degradation products? Let me ask you one thing. You just tell me, sir, if I am the person who is having disseminated intravascular coagulation, in my body unnecessary clots are being formed. Unnecessarily the fibrinogen is getting converted into fibrin. So unnecessarily clots are formed in my body. So what my body will try to do? My body will try to remove the clots. Okay, if there is a platelet microthrombi, my body is going to target it. My body is going to target it and try to remove the clot. So during this process, lots of this fibrin is going to be broken down. All the fibrin, whatever is forming unnecessarily, will be chopped up. So those fibrin degradation molecules, the fibrin degradation products are called as D dimers. So you will have more D dimers. My body is trying to do or I should say my body is going to do thrombolysis. My body is trying to do thrombolysis. So during this process, the thrombin is going to be broken down, leading to the formation of these molecules called as D dimers. They are fibrin degradation products, and these D dimers are the most, the best screening. They are best screening test. Okay, best screening test for DIC. Okay. Now, what is the treatment, sir? The treatment is going to just treat the underlying cause. I have said you there is some primary cause. You just try to treat the primary cause. If you treat the primary cause, yes, it's completed. Next, what else you can do is, so this patient is getting deficient in the clotting factors. If this patient is getting deficient in the clotting factors, so just try to give the cryoprecipitate. And try to do the transfusions. The transfusion of the blood products. This you can transfuse the platelets, you can transfuse the clotting factors, the cryoprecipitate. Okay, the cryoprecipitate which contains the clotting factors. This cryoprecipitate is nothing but it contains clotting factors. Okay, so completed. Now with this disseminated intravascular coagulation, whatever the points which I want you to know are completed. So disseminated intravascular coagulation completed. Now let me talk about the fibrinolysis. First, normal fibrinolysis. Normal fibrinolysis. And after that, I will discuss about the disorders of fibrinolysis. First of all, what is normal fibrinolysis? See, for example, imagine, see, there is a blood vessel which is damaged. Now, whenever the blood vessel is damaged, what you need to do? First, you need to form the platelet plug, upon which you need to stabilize the platelet plug by the formation of clotting cascade. Okay, with the help of the clotting cascade, you need to stabilize it. Okay, simple. Once the blood vessel is healed, once healing completes, what you need to do? You need to remove the thrombus. We don't want the thrombus now. Okay, we have to simply break down that thrombus. We have to remove that fibrin from there once the healing is completed. So this process is called as a fibrinolysis. In the name itself, it's there, fibrinolysis, fibrin breakdown. Once healing completes, you need to do that. So how it will happen, sir? Let me tell you. See, there is something called as tissue plasminogen activator. Okay, let me write. Okay, let me put it this way. So this is something called as a plasminogen. See, wherever you see the word ogen, ogens are all inactive. Okay, so this plasminogen need to be converted into plasmin. Okay, what you need to do? You need to convert the plasminogen into plasmin, sir. For this process, what do you require? You require tissue plasminogen activator. Okay, TPA. Okay, let me write full form. tissue plasminogen activator. So who produces this tissue plasminogen activator? Endothelial cells. Endothelial cells. They are releasing this molecule called as a TPA. So tissue plasminogen activator. Once the healing is completed, once now the blood vessel is absolutely proper, okay, properly lined with endothelial cells. Now this endothelial cells, what they will produce? Something called as a tissue plasminogen activator, which will convert the plasminogen into plasmin. Now what this plasmin will do, sir? See, this plasmin is going to inhibit, okay, fibrin, or I can say whatever the fibrin is there will be broken down. Plasmin is going to break the fibrin. It will break down the fibrin, and it won't even allow the fibrinogen to come into that area. Once if the fibrinogen is coming to that area, even the fibrinogen will be broken down. So fibrin as well as fibrinogen will be broken down, or to that matter any clotting factor, okay, activated clotting factors. All these clotting factors are getting chopped down immediately. The plasmin, it's a destructive thing, okay. So plasmin inhibits the fibrinogen, clotting factors, as well as very important thing, the plasmin also inhibits platelet aggregation. Okay, so preventing the new thrombus formation. So at the end of the day, the point which I want you to know is, so once you have plasmin is anti-clotting, anti-thrombosis, anti-clotting, okay, anticoagulant. It acts like an anticoagulant, anti-thrombosis. It breaks down the existing clots. It chops down the fibrin. So clot will be totally dissolved. Okay. See, in our body, every activity is properly being regulated. Okay. See, for example, here it looks like plasmin is like a king. What it is doing? It's causing the destruction. Okay, destruction. But even the plasmin activity need to be regulated. We need to regulate the activity of plasmin. So who inhibits the plasmin? Okay, who inhibits the plasmin? There shouldn't be overaction. The activity needs to be properly regulated. There is something called as alpha 2 anti-plasmin. Okay, there is something called as alpha 2 antiplasmin. See, this alpha 2 antiplasmin is produced by liver. Okay, liver is producing this protein which is called as the alpha 2 antiplasmin. So this alpha 2 antiplasmin inhibits the plasmin, means regulating the activity. Okay. Next point is, so this plasmin activity is also activated. There is something which is called as, let me write here, urokinase. This urokinase activates the plasmin. Okay, urokinase activates the plasmin. So once the plasmin is activated, you know the things. Okay, so this is what I want you to know. This is how normal fibrinolysis is acting, like acting. See, there is someone who is inhibiting the plasmin, and there is someone who is activating the plasmin. So the plasmin activity is properly being regulated. And what is the function of plasmin? Plasmin is anti-clotting, anti-thrombosis. Okay, you know it. Now let me discuss about the disorders of fibrinolysis. Okay, what are the disorders, sir? Disorders of fibrinolysis. Sir, in this disorders, what exactly is happening? Let me tell you. In a simple way, I can say there is overaction. Whose overaction? Plasmin overactivity. Okay, there is plasmin overactivity, sir. So why the plasmin is getting overly activated? You know it. Once the plasmin is overactivated, you know the things. The plasmin is going to destroy the fibrinogen, clotting factors, platelet aggregation is not going to happen. So bleeding will occur, sir. Clotting is, see, I should say, for example, if the unnecessarily plasmin is getting overactivated, guys, what plasmin will do? Overactivity of the plasmin will cause the destruction of all the clotting factors. All the clotting factors just like that are getting broken down. So we are getting deficiency of the clotting factors, which can actually cause the bleeding, which can lead to the bleeding disorders, right? So question is, why plasmin overactivity? The conditions are, one is radical prostatectomy. Prostatectomy. Okay. Radical prostatectomy. Radical prostatectomy. See, this radical prostatectomy is going to release urokinase. Okay. Suddenly, it's going to release lots and lots of urokinase. While you are doing the prostate resection, during the surgical process, urokinase is going to be released. This urokinase is the one, it. So, what urokinase will do? Urokinase is the activator of plasmin. So, plasmin is getting overactivated. Overactivity of the plasmin will cause anti-clotting. So, clot is not going to form. Now, when the clot is not going to form, so more and more bleeding. Okay, more and more bleeding is going to occur. Okay, radical prostatectomy. Next, cirrhosis of the liver. Cirrhosis. Okay, liver cirrhosis. Now, how liver cirrhosis? Okay, how liver cirrhosis is going to cause disorders in the fibrinolysis. Now, when the liver cirrhosis means what? The liver is getting fibrotic. The liver is totally replaced by the fibrotic tissue. Means liver failure, right? Almost liver failure. Now, liver is not producing alpha 2 antiplasmin. See, now alpha 2 antiplasmin is not there. This fellow is not there. Okay, this alpha 2 antiplasmin, now he is not there. When alpha 2 antiplasmin is not there, now is anyone inhibiting the plasmin? So, no inhibition. If no inhibition means overactivation. Overactivation can lead to over-destruction of the clotting factors. Over-destruction of the clotting factors can lead to bleeding. Okay, so second reason also completed. So, radical prostatectomy as well as cirrhosis of the liver. So, what you will see in the labs? Okay. In the labs, what you will see? See, these patients are going to have, what about the PT-PTT times? The PT and PTT, they are both elevated. What happened to bleeding time? Bleeding time, what do you think? The bleeding time is increased. Why bleeding time is increased? Because I have said you, overactivity of the plasmin inhibits the platelet aggregation. The platelets are now not getting aggregated. The platelets are not coming close together. Without platelet aggregation, primary platelet plug is not going to form. Without primary platelet plug, bleeding. So, if there is defect in platelet adhesion or aggregation, platelet related problems, any platelet related problem is going to increase the bleeding time. The same thing, bleeding time is going to increase. Okay. And what else I want you to know is, so these patients, how to treat these patients? Okay, treatment is, so there is overactivity of the plasmin. Plasmin is doing the overaction. So, what we have to do? We have to make the plasmin to go into the sleep. We have to inhibit the plasmin. So, plasmin inhibitor, okay, that is aminocaproic acid. So, what this aminocaproic acid is going to do? Aminocaproic acid is going to inhibit conversion of, okay, inhibits conversion of plasminogen into plasmin. So, this conversion is inhibited. So, what happened to the plasmin levels? Plasmin levels goes down, means the overactivation is getting reduced. So, let me put here itself. So, who is inhibiting this process? This process is being inhibited. Okay, it's being inhibited by aminocaproic acid. Okay, aminocaproic acid. So, done with this normal fibrinolysis and the disorders of fibrinolysis, the two important conditions during radical prostatectomy, there will be overactivity of the plasmin, and during liver cirrhosis also, due to deficiency of alpha 2 antiplasmin, there is overactivity of the plasmin. Okay. Next, after this, let's discuss about the next topic, that is thrombosis. Okay. So disseminated intravascular coagulation, and the topics are completed. Next topic is thrombosis. So what exactly is thrombosis? You know about the thrombi, right? The formation of a clot. That's good or bad? See, if there is thrombi formation, whenever there is a damage to the blood vessel, see, whenever there is a damage to the blood vessel, and in that particular place, if there is formation of thrombi, that's okay, good. But if you form this thrombi unnecessarily, okay, if you form the thrombi unnecessarily, that's a bad condition, definitely that's a bad condition. That's a pathological, right? So, thrombosis is not physiological, it's a pathological formation, okay, pathological formation of what? Of intravascular clot. Okay, intravascular blood clot. Now this intravascular blood clot, which is pathologically formed. So usually we use like the word thrombi very commonly, but thrombosis is always pathological. Okay, so pathological formation of intravascular clot is called as thrombosis. Now, see, what are the causes? What are the causes of thrombosis? The causes of the thrombosis include three causes. These three causes are classically shown with a triad, okay, which is called as Virchow triad. Okay, Virchow triad, VRCHDCW, Virchow triad. Sir, what are these three causes? The three causes includes number one, that is endothelial damage. Endothelial damage. Second, alteration of normal blood flow. Alteration of normal blood flow. And the third condition is hypercoagulable states. Okay, hypercoagulable states. If we discuss about these three conditions, then the topic of today will be complete. The major topic for today will be completed. Okay, so let's discuss about one by one in detail. First, let's begin with the alteration in the normal blood flow. Let's begin with this. Okay, how alteration in the normal blood flow is going to cause thrombosis? Okay, what are the causes? What are the alterations in the blood flow? Let me write. So, alteration in normal blood flow. Okay, alteration in the normal blood flow. First of all, what is normal blood flow? Normal blood flow is called as linear or laminar blood flow. Okay, so there is something called as laminar blood flow. Laminar blood flow. Okay, which is a proper regularized blood flow within the blood vessels. The blood is going with such a uniformity. They are going like a soldiers, like how the soldiers will march. Okay, so the blood cells are also going in a very perfect uniform fashion. Okay, they are not going in a sluggish way. They are not going in haphazard way, irregular way. No, it's going in a very streamlined fashion. Okay, so yes, laminar blood flow is there. The alterations. What are the alterations? Disruptions in the normal blood flow. Two. One is stasis, and the second condition is turbulence. So, whenever there is a stasis or turbulence, that can cause alteration in the normal blood flow pattern. So, in which conditions you can see the stasis? Okay, which condition you can see the stasis? For example, when you are immobile for a lot of time, you are just a patient who had surgery and you are immobile for a lot of time. There is immobility for long periods of time. So, that immobility can lead to stasis. Okay, so the immobility can lead to stasis. So there is alteration in the normal blood flow. Now the blood flow is altered. Now whenever there is a stasis, the blood is going very slowly in a sluggish way. Now this alteration in the blood flow is enough. to form the clots. Okay, to form the clots. Okay, within the blood vessel without even damage. The blood vessels are not damaged. So just the blood flow pattern is changed from the laminar blood flow to stasis. The blood is going very slowly. Okay, so now the platelets in such a slow moving blood or the blood which is absolutely stagnant, the platelets will be activated. They will form the clot. Okay, they will be activated. So platelets will start to attach with one another. Platelet adhesion, aggregation, followed by the clotting cascade can happen. So immobility. Next, what else? So the patient is having aneurysms. Okay, aneurysm. So what are these aneurysms? Aneurysms are pathological dilatation of a blood vessel. Okay, so permanent pathological dilations of a blood vessel. For example, now imagine this is a blood vessel which is having this aneurysm, berry aneurysm, something like this, a saccular aneurysm. Blood is coming like this. Now it is going here. Now as the blood is going into this area, now there is change in the blood flow pattern. Now it is getting a whirlpooling here. Okay, so this is turbulence. Turbulence can happen with the aneurysms. See, if there is an aneurysm in the heart, within the heart itself, okay, because of the myocardial infarction, okay, as a complication of myocardial infarction, there is aneurysm to the heart. So whenever there is aneurysm in the heart, within the heart itself, the blood is getting turbulent. Okay, now the blood is getting turbulent. If there is turbulence, there is a chance that the platelets will be activated. That in the turbulent blood flow, that platelets will be activated. They will cause a degranulation and they will lead to start the activation of the clotting. Okay, then clots can form. One thing, or if the patient is having certain disorders like atrial fibrillation, AFib. So atrial fibrillation, see, you know it. It's a cardiac wall defect, means there is some defect within the wall of the heart. Atrial fibrillation, what exactly is going to happen? The atria are just quivering like this. They are not contracting. They are not properly contracting. Atria are just quivering like this. So there is going to be a relative stasis, okay, within the atria. Now this blood can form the mural thrombi. The blood can form the thrombi within the heart wall because the atria are just shaking like this. They are quivering like this. They are not contracting. So stasis can occur in this area, so that can lead to the formation of platelet microthrombi. The thrombi is going to attach to the wall of the heart. So at the end of the day, the points which I want you to know is prolonged immobility or aneurysms, like vessel defects like aneurysms or heart wall defects. Okay, heart wall defects like atrial fibrillation. Okay, they can all lead to alteration in the normal blood flow. Okay, or arrhythmias. Okay, atrial fibrillation is arrhythmia or any form of arrhythmia where the blood is going to be totally churned out because of the arrhythmias. The blood is getting churned out, so that can lead to the formation of thrombi. So first thing is completed. Second condition is endothelial damage. The endothelial damage is going to cause thrombosis. It's going to cause a thrombosis. Three things will cause the thrombosis. What are the three things that will cause the thrombosis? Endothelial damage, alteration in the normal blood flow, and hypercoagulable states. One thing we have completed, this thing we have completed. Now we are discussing about the endothelial damage. So endothelial damage can lead to thrombosis. But if you have normal endothelium somehow is preventing the thrombosis, right? So healthy endothelium always prevents thrombosis. How? How, sir? The question is how this endothelium is preventing the abnormal formation of the thrombi. Is first thing you need to understand, this endothelial lining is acting like a barrier. For example, look here, this is a blood vessel. Okay, the blood vessel. Now in the blood vessel, who is there? What is this? The blood vessel is made up of collagen. Okay, in the blood vessel wall there is collagen, subendothelial collagen. Okay, there is collagen, sir. So here is our endothelial cells. Here are the endothelial cells. So till the time endothelial cells are there, till the time endothelial cells are there, the plasma is not coming into contact with the collagen. It's not coming into contact with the collagen. If there is any damage, okay, there is any damage to the endothelial cell. Now what happens? The plasma is now directly touching to the subendothelial collagen. Now, in yesterday's class we have discussed the subendothelial collagen it's going to activate the intrinsic pathway. Subendothelial collagen is the one which activates the clotting factor number 12. 12 activates 11, 11 activates 9, 9 to 8, 8 to 10, you know it, you know the story. So subendothelial collagen will activate the clotting. So who is acting like a gate? Who is acting like a barrier by preventing the exposure of subendothelial collagen? It's endothelial cells. So right? Endothelial cells prevent exposure of subendothelial collagen and prevents the thrombosis. First thing. Second, this endothelial cells, they produce certain chemicals. Okay, these endothelial cells are releasing certain chemicals. For example, see these pink color chemicals that are coming out. Endothelial cells, healthy endothelial cells, they are releasing these chemicals. What is this chemical? The chemical number 1 is called as prostaglandin I2. Okay, prostaglandin I2. So what prostaglandin I2 will do? Then the inflammation topic also we have discussed in the cyclooxygenase pathway. The prostaglandin I2 is also called as prostacyclin. Okay, this prostacyclin is the one which is going to cause the vasodilation. Okay, the vasodilation. Not only that, these prostacyclins will inhibit the platelets. Prostacyclins will inhibit the platelet aggregation. Okay, it inhibits the platelet aggregation. So it inhibits the platelet aggregation followed by clotting and thrombosis. Okay, so in a healthy blood vessel, the healthy endothelium is always producing this prostacyclins, prostaglandin I2 inhibits the unnecessary formation of the clots. Not only that, these endothelial cells are also going to produce something called as nitric oxide. Okay, nitric oxide, NO. So this nitric oxide is also vasodilator. Okay, it's also vasodilator, also going to inhibit the platelets, also inhibit the platelet aggregation. Okay, next, these endothelial cells, they will produce certain molecules called as heparin-like molecules. Heparin-like molecules. So what these heparin-like molecules are going to do? So these heparin-like molecules, they are going to, these heparin-like molecules are going to activate something called as antithrombin 3. Okay, this is already there in our blood. It's always there in our blood. It's always there. So this antithrombin 3, it's always there in the blood. The name itself is there if you just look at it. So it's the antithrombin, antithrombosis. Unnecessarily, if there is any clot, this antithrombin 3, it will break down the clotting factors. The point which I want you to know is, see in your blood, there are clotting factors and there are anti-clotting factors like plasmin, nitric oxide, okay, and prostacyclins, antithrombins. Okay, later I will discuss protein C, protein S. So at the end of the day, what I want you to know is, in your blood vessels, there are certain pro-clotting factors, there are certain factors which helps in coagulation, and there are certain factors which are anticoagulants, procoagulants, anticoagulants. So there is always a balance between them. Okay, coagulation, anticoagulation factors, there is always a balance between them. So always in your blood also, there is something called as antithrombin 3. See, it is antithrombosis. Okay, who is activating the heparin-like molecules, the heparin drug, whatever is available, the heparin. Okay, yesterday's class I have discussed about warfarin. Warfarin inhibits vitamin K activation. Okay, warfarin inhibits like vitamin K epoxide reductase. In yesterday's class I have discussed. In the same way, heparin, what it will do? So heparin is going to activate this antithrombin 3. In our blood also, heparin-like molecules are there. Who is producing these heparin-like molecules? Endothelial cells. Endothelial cells release heparin-like molecules. The heparin-like molecules activates the antithrombin 3. Always there in our blood. The antithrombin 3 is going to destroy clotting factors. going to destroy the clotting factors and also going to destroy thrombin. Okay, in the name itself it's an anti-thrombin. It inhibits thrombin. So what is thrombin? Thrombin is clotting factor number 2. Okay, prothrombin need to be converted into thrombin. So thrombin converts soluble fibrinogen into insoluble fibrin, the last step. Okay, so done. Next, fifth one, the last thing which I want you to know is thrombomodulin. These endothelial cells, what they are doing? They are secreting a substance called as thrombomodulin. The name itself is there. See, it is modulating, means changing the activity of the thrombin. Thrombin normally helps in the formation of clot, but this thrombomodulin, okay, what it will do is the thrombomodulin changes the function of the thrombin. So now thrombin becomes anti-clotting. Normally it is pro-clotting, it's a procoagulant, it's going to cause the clot formation. But this thrombomodulin, it will change the function to anti-clotting. Okay, so what this thrombomodulin is going to do? It's going to convert, or I should say, it's going to make thrombin. Okay, it's going to make the thrombin to activate something called as protein C. Okay, protein C. So once this protein C is activated, it is going to, protein C is going to inactivate clotting factors. Which clotting factors? This is important. Clotting factor number 5 and clotting factor number 8. Okay, done. So this thrombomodulin is secreted by the endothelial cells. Thrombomodulin activates the thrombin. Thrombin activates protein C. Okay, thrombin activates protein C. So protein C inactivates clotting factor number 5 and 8. 5 is required for the common pathway, 8 is required for the intrinsic pathway. So clotting is not going to happen. So at the end of the day, the point which I want you to know is, see, a healthy endothelium, a healthy endothelium always anticoagulant, anti-clotting. So the moment you have the disruption of the endothelial lining, the endothelial cells are getting damaged. When the endothelial cells are damaged, such protective functions are lost. Nitric oxide production, prostaglandin I2, okay, prostaglandin I2 release, like is not going to be there. Now the subendothelial collagen is going to be exposed. Now the heparin-like molecules are not going to be released. Thrombomodulin is not going to be released. So this anti-clotting function is going to go down. Now pro-clotting function will be more. Okay, so more and more clots will form. So at the end of the day, thing is completed, sir. Endothelial damage is completed. Okay. Next, why endothelial damage? Now let's take the causes of endothelial damage. One thing I have already, one thing I forgot here. Actually, I should mention here, worth mentioning. Me take. So there is something, right? So there is production of tissue plasminogen activator, endothelial cells. You already know it. In the beginning I have explained you. Okay. Here, see. The endothelial cells also produce something called as a tissue plasminogen activator, TPA. The tissue plasminogen activator is going to activate the plasmin, and I have explained plasmin is anti-clotting. Okay. Endothelial cells secrete tissue plasminogen activator. Tissue plasminogen activator. It converts plasminogen into plasmin. Plasmin is anti-clotting. Plasmin is anti-clotting. So done. So these are the protective functions. After protective functions, now let's discuss causes of endothelial damage. The causes of endothelial damage. So what are the causes of endothelial damage, sir? Number one cause is B9 and B12 deficiency. Now you can ask me how the B9 and B12 deficiency is going to cause the endothelial damage. Because in yesterday's class also I have explained you, not in yesterday's class, in RBC disorders, like especially in macrocytic anemias I have discussed. See, vitamin B9, the tetrahydrofolate, okay, once it enters into your body, it will get methylated. Okay, it's going to be methylated, the tetrahydrofolate. But this tetrahydrofolate donates this methylated methyl group to vitamin B12. So now this vitamin B12 is having this methyl group. Now this vitamin B12 acts as a methyl donor. It acts as like a methyl donor for homocysteine. So now this homocysteine will be converted into the homocysteine will be converted into methionine. Okay, so by accepting this methyl group, by accepting that methyl group, the homocysteine will be converted into methionine. So vitamin B9 and B12 are required for this donation of this methyl group. By accepting the methyl group, methionine is getting synthesized. For example, vitamin B9 is not there, vitamin B12 is not there. So what happens? There is no methyl donor. So what happened to the homocysteine levels? Homocysteine levels are elevated. So now this condition is called as a homocysteinemia, high levels of homocysteine. Now this homocysteine is the one which causes the endothelial damage. Is the one which causes the endothelial damage. So once there is endothelial damage, that causes thrombosis. Okay, so the patients who are having high levels of homocysteine, like high levels of homocysteine, yes, there is a chance that they can develop the thrombosis. Okay, so this is a one cause. Next cause is deficiency of an enzyme called as cystathione beta synthase. Cystathione beta synthase deficiency. Cystathione beta synthase deficiency. So what is this enzyme? Cystathione beta synthase is actually a biochemistry thing. The cystathione beta synthase is required for the conversion of homocysteine into cystathione. Okay, you require this enzyme. Cystathione beta synthase is required for the conversion of homocysteine into cystathione. When this enzyme is not there, again homocysteine levels are going to be elevated. More and more homocysteine levels will be seen. This homocysteine will go out of the body. So deficiency of CBS is going to cause homocysteinuria. Homocysteinuria means high amounts of homocysteine is there and that is going out of the body in the urine. Homocysteinuria. Okay, so in these patients who are having this homocysteinuria, okay, they are also going to have the thrombosis. Okay, these patients are going to have thrombosis, especially from the biochemistry. This is very much important. Cystathione beta synthase deficiency is going to cause homocysteinuria. Thrombosis will be seen. These patients are going to have this homocysteine levels, will cause damage to the brain, that will cause the mental retardation. Okay, and lens dislocations. Okay, lens dislocation can be seen. These patients are going to have spider-like fingers, which is also called as the arachnodactyly. Okay, arachnodactyly are long, slender fingers. So the point which I want you to know is, see, these patients who are having this homocysteinuria due to deficiency of this enzyme cystathione beta synthase, they are going to have Marfan-like features. See, this long, slender fingers, this lens dislocation, these are actually features of Marfan syndrome. So they are going to have Marfanoid habitus. Okay, they are going to have Marfanoid habitus. That is the point which I want you to know, sir. Okay, so done. So with this, we have completed the second thing also, that's the causes of endothelial damage. So endothelial damage, the most important point which I want you to know is homocysteine levels. Okay, homocysteine levels can cause endothelial damage, and other damages like smoking, like etc. Smoking can cause damage to the endothelial cells. Alcohol can cause damage to the endothelial cells. Hypertension can cause damage to the endothelial cells. Okay, so these are all miscellaneous things. Okay, so smoking, alcohol, hypertension, atherosclerosis, all these things can cause damage to the endothelial cells. Once the endothelial cells are damaged, these protective mechanisms are going to last. What are the protective mechanisms? Again, I am telling you, nitric oxide production, prostacyclin production, heparin-like molecules production. Okay, and tissue plasminogen activator production, TPA, tissue plasminogen activator production. Okay, so these things, thrombomodulin production, these things are not going to happen, so automatically thrombosis. So procoagulants are going to be more, anticoagulants will go down. Okay, nitric oxide, TPA goes down, thrombomodulin goes down. Okay, so they will go down. So more clotting, more clotting. Now, the last one which I want you to know is hypercoagulable states. Hypercoagulable states. So what are these hypercoagulable states? Hypercoagulability, they are going to, there are certain conditions which can cause the hypercoagulability, which can cause the hypercoagulability of the blood. Means the blood is getting more and more coagulable, which means simple. The clotting factors are getting increased, anti-clotting factors are going to go down. Okay, anti-clotting factors are going to go down. So what are the factors of this hypercoagulable states? Examples. Okay, the examples are number one, protein C and S deficiency. The deficiency of protein C and S. The protein C and S, they are anti-clotting factors. They are anti-clotting factors. So they all the time, what their work is means anti-clotting, anti-clotting, anti-clotting. If you are having deficiency of this anti-clotting factors, so I have said you there should be always balance procoagulants, anticoagulants. When you decrease the anticoagulants, procoagulants will look more, relatively more, so that can cause hypercoagulable state, that can cause actually the thrombosis. Okay, that the thrombosis within the blood vessels. Okay, next, factor 5 Leiden mutation. Factor 5 Leiden mutation. So what exactly is happening, sir? See, the factor number 5 need to be cleaved down. Okay, once the function is completed, you need to break down the clotting factors, right? Okay, you need to break down the clotting factors. But because of this Leiden mutation, now what you are having is a clotting factor which is not going to be destroyed. Normally, let me tell you, this protein C, I have explained in the beginning also, protein C and S. Okay, protein C and S. Look here, let me show you. See, thrombin, see, the thrombomodulin is making the thrombin to activate protein C. What the protein C and protein S will do? They inhibit the factor number 5. Okay, they inhibit the factor number 5. But what kind of clotting factor number 5 we are having right now? Because of a mutation, now we are having a resistant clotting factor number 5 which cannot be degraded. Now you cannot degrade this clotting factor number 5 because of this Leiden mutation. So protein C and S, it cannot break down the clotting factor number 5. Okay, so that will lead to hypercoagulable states. Hypercoagulability means there is overactivation of the clotting number 5. Okay, overactivation of the clotting factor number 5, sir. This is one thing. Next, deficiency, the third one which I want you to know is deficiency of antithrombin 3. Okay, antithrombin 3 deficiency. So how one can get antithrombin 3 deficiency? Okay, how one can get? See, antithrombin 3, it is present in our blood. It's there in our blood. It's a plasma protein, for example. Let's put it there. Put it like this. Okay, it's a plasma protein. Antithrombin 3. It's a plasma protein, sir. If you are having a nephrotic syndromes, okay. So in nephrotic syndromes, you know it. So nephrotic syndromes, there is loss of proteins. Okay, loss of proteins in the urine every day. There is loss of proteins more than 3.5 grams per 24 hours. Every day, this much amount of proteins are lost in the urine. This much amount of proteins are lost in the urine. So one of the protein that's going to be lost out of the body is antithrombin 3. One of the protein that's going out of the body is antithrombin 3. So the patient is losing continuously losing antithrombin 3. So in the name itself is there, it is antithrombin, anti-thrombosis, anti-clotting. You are losing the anti-clotting factors. You are losing the anti-clotting factors. So what happens? The procoagulants, the clotting factors are going to be look more, so more hypercoagulable. So at the end of the day, the point which I want you to know is, sir, in hypercoagulable states, okay, in hypercoagulable states, the point is there is excessive, okay, excessive what? Excessive procoagulant activity. There is excessive procoagulant proteins. Why there are excessive? Actually, their number is not increasing. Okay, procoagulant number is not increasing. Rather, the anti-clotting. Okay, anti-clotting factors are going down. Antithrombin 3 levels less. Protein C and S levels deficiency. Factor 5 lead and mutation. Factor 5 lead and mutation, you know it. You cannot break down that. Factor number 5. Okay, so with this we have completed uh, the Virchow triad, the three components of the Virchow triad: endothelial damage, hypercoagulable states, as well as the alterations of the blood flow, that is stasis, as well as turbulence because of aneurysms or arrhythmias, atrial fibrillation. We have completed. The one thing I want to add here is, sir, certain drugs like oral contraceptive pills, OCPs, what they will do, oral contraceptive pills, they are nothing but the estrogen and progesterones, right? So it's nothing but the combination of estrogen and progesterones. This estrogenic component, estrogen C, it stimulates the clotting factors. Okay, it stimulates the clotting factors in the sense it increases the number of clotting factor synthesis. It increases the clotting factor production. Okay, estrogens by acting on the liver, increases the clotting factor number. So estrogens will make the blood hypercoagulable. True. Okay, in hyperestrogenic states, there is a risk of thrombosis. Absolutely true. Why? Because high levels of estrogens will stimulate the liver to produce more and more clotting factors. More and more clotting factors means more and more hypercoagulable states. Now the blood is more favorable to produce the clots. That. Next, what else I want you to know for your exams is how to differentiate the real thrombus versus post-mortem clot. Okay, so post-mortem clot, thrombosis versus post-mortem clot. The thrombosis is going to be seen during life stage when the person is alive and he is having abnormal clot formation, abnormal thrombus formation within the blood vessels. Okay, post-mortem clot means what? After the death, the blood is not going to be in circulation. As the blood is not in the circulation, again blood will clot, sir. Okay, now imagine you are having a dead person. Okay, you are having a dead person. Now you are doing the autopsy. Okay, now within the coronary arteries, you are seeing a clot like this. Now you want to know whether this clot is a thrombus or is it a post-mortem clot. Okay, after the death, see, this clot is forming after the death of the person, or this clot, the thrombus, is the cause of the death of the person. You want to know it. So first of all, if I see an image like this within the blood vessel and there is a clot, now I will say this is not a thrombus. This is not a thrombus. This is a post-mortem clot. How can I say it's not attached with the wall? It is not attached with the wall. So first write post-mortem clots. Okay, the post-mortem clots. Okay, let me write here itself. They do not attach with the wall. Not attached. Okay, not attached with the vessel wall. Next, sir, if it is a real thrombus, okay, if it is a real thrombus, it is attached with the wall, and what you can see under histology is, sir, clot is like, the thrombus is going to form gradually. Okay, the thrombus is not going to form just like that. So more and more RBCs will come. You are going to put a fibrin over it, and more RBCs will come. Again, you are putting more and more fibrin onto it. Again, RBCs, platelets are coming. You are putting more and more fibrin onto it. So clot is going to gradually increase in size. So if you look under the histology, okay, this thrombus is going to look something like this with multiple lines. These lines are called as lines of Zahn. Okay, they are called as lines of Zahn. Okay, they are called as the lines of Zahn. So lines of Zahn, they are nothing but the, for example, here you can see the RBCs, here fibrin, RBC platelets with fibrin, RBC platelets with fibrin. So it's a lines. Okay, it's a appearance. This is called as the lines of Zahn, and these lines of Zahn are going to be seen only in a thrombus, not in a post-mortem clot. That's the point which I want you to know. So what happens if the thrombus, okay, if it is dislodged from that area, the thrombus is dislodged from that area. Okay, so this is the blood vessel. Now the thrombus is dislodged from the vessel wall. Now it is traveling within the blood. It is circulating within the bloodstream. Then it is called as embolus. So what is embolus? The embolus or embolism is nothing but the intravascular mass that is traveling. Okay, it's an intravascular mass. See, now within the blood vessel, there is a mass that is traveling, which is nothing but a detached thrombi. It is nothing but a detached thrombi. So you can also say thromboembolism. Thrombus got detached and now it became an embolus. So thromboembolism. And this emboli is going to definitely 100% it's going to block a blood vessel. Okay, as it is going through the smaller blood vessels, it will definitely block the blood vessel. So this intravascular mass that is traveling and going to block the blood vessel is called as a embolus. Okay, embolus. Now question is, what are the causes of embolus? Okay, causes. Say 90% or even I should say 95% of the time, the cause is thromboembolism. Okay, thromboembolism means there is a thrombus which got detached and became an embolism, thromboembolism. And what is the most common site of this thrombus? The most common site of the thrombus is going to be deep veins within the leg, below the knee, deep veins, okay, within the veins. So deep venous thrombosis, it's getting embolized. This is the number one cause. Other causes include gas embolus. Sir, why you can have this gas embolism? Gas embolism, see, imagine you are a sea diver, okay, you are diving into the sea, okay, with the cylinders and all the stuff. Now, as you are going deep into the sea, as you are going descend down into the sea, the pressure increases. The pressure which is exerted on your body is going to be super tremendous. Okay, the sea or the ocean is going to exert pressure on your body. Okay, that's okay. But while you are ascending up, actually you should be very much careful. You should come slowly. You should ascend up. Okay, going down. Okay, but when you are coming back, you should not come up very fastly. When you are coming up very fastly, a fast ascension is going to cause the precipitation of the nitrogen gas. The nitrogen gas precipitates out of your blood. Okay, in our blood, oxygen is there, everything is there, but they are absolutely in dissolved form. Okay, oxygen is binding with the hemoglobin, oxygen is binding with the hemoglobin, and some amount of oxygen is dissolved in the plasma, and the nitrogen is also dissolved. But when you are having such a rapid ascension, the nitrogen gas precipitates and forms bubbles, gas embolism. So, gas embolism can be seen in sea divers during rapid ascension. Okay, during rapid ascension. Okay, gas embolism can be seen. Now, where else, sir? See, for laparoscopic surgeries also, okay, these days we will do like most of the surgeries are being done with the laparoscopy only, right? So, during laparoscopy, what we will do, we will put some gas, especially carbon dioxide gas. Okay, we will put the carbon dioxide gas and we will try to inflate so that we will have a better field, okay, for the surgery. So, that carbon dioxide gas can enter, the gas can enter into the blood vessels, okay, through the bleeding blood vessels, and there can be a gas embolism. So, gas embolism seen in sea divers during rapid ascension, where nitrogen gas is going to precipitate and forms this gas embolism. The second cause, okay, the second cause, let me put it this way, A and B. The cause number B is during laparoscopic surgeries. Okay, during laparoscopic surgeries, you can have gas embolism. True, because of the carbon dioxide gas that is entering into the blood vessel. Now, what are the other causes of embolism? Number one cause is thromboembolism. Number two, gas embolism. There can be fat embolism. So, fat embolism is seen in which conditions? Fractures. Point which I want you to know is fractures within your bone marrow. Okay, see, within your bone marrow, what do you have? You are having the fat cells. Okay, fat cells, like bone marrow is having lots and lots of fat, yellow bone marrow. So, whenever there is a fracture, this fat droplets are going to leak, and if there is any damaged blood vessel, through the damaged blood vessel, this fat can get access into the blood vessel and it is going to get embolized. Okay, and it's going to it's going to block the blood vessels also. So fat embolism can be possible. So I have discussed here 3 types of embolism: thromboembolism, gas embolism, fat embolism, and the last embolism which I want you to know for you is amniotic fluid. You already know it, embolism. Amniotic fluid embolism I have discussed. So the amniotic fluid is entering into the maternal circulation. The amniotic fluid which is rich in the tissue factor, is going to cause a disseminated intravascular coagulation. Okay, disseminated intravascular coagulation within the mother. So consumptive coagulopathy, the platelets are getting consumed, the clotting factors are getting consumed. So here the amniotic fluid is acting like an embolism. Okay, so there are different types of embolism: gas, thromboembolism, gas embolism, fat embolism, amniotic fluid embolism. So most of the times in exam they will ask you fractures, fat embolism. Amniotic fluid embolism can lead to TIC. Laparoscopic surgery can cause gas embolism. So this emboli, where they will go? So for all these veins, okay, most of the time this emboli are coming like this. This emboli, where they will go? Emboli at the end of the day, they will go into your right side of the heart. Okay, that means it's coming to the right side of the heart. From the right side of the heart, they are going to the right ventricle, right atria, right ventricle. From the right ventricle, where it's going to go? To the pulmonary blood vessels, through the pulmonary artery. This embolus is traveling into the lungs. So in the lungs, the embolus is going to get blocked. Okay, it's going to get blocked, leading to pulmonary embolism. Pulmonary embolism. Okay, so this pulmonary embolism is going to have this wedge-shaped, infarcts in the lungs. Okay, it's going to cause this wedge-shaped infarct. Okay, it's going to cause the wedge-shaped infarct. So with this, the pulmonary embolism topic is also, the embolism topic is also completed, guys. So I have discussed different types of embolism. If there is pulmonary embolism, you can see such wedge-shaped infarcts. So with this, we have completed all the platelet disorders in yesterday's class and today's class. All the platelet disorders, whatever you need to know, they are completed. Hope the class is helpful. See you in the next class with other new topic. Thank you.